Okay, let's dive into a topic that is absolutely crucial for your anesthesia exams. This whole explainer is designed to help you completely master the legal, ethical, and clinical principles you'll need for managing patients who decline blood products.
So, where do we start? Well, maybe not where you'd expect. We're going to begin with the human side of things. This quote from the source article is so important because it reminds us that at the center of all this complexity, there's a person whose beliefs and autonomy we have to respect with real compassion and understanding.
All right, here's our roadmap. We're literally going to follow the patient's journey step by step. We'll start with the ethical foundations and work our way all the way through to some very specific high-risk situations. This gives you a really logical framework for your revision, which hopefully makes it way easier to remember when you're under pressure.
Okay, first things first. Let's lock in the fundamental principles that guide everything we do. You know, this isn't just about what we do, it's about why we do it. Getting this bit right is the absolute bedrock of safe and lawful care. The core principle here is patient autonomy. And for your exam, you have to remember this. In the UK, treating a competent adult without their permission isn't just bad form, it's unlawful. It's actually considered assault. And that right to say no holds up even if we as clinicians think it'll save their life.
The key piece of legislation to have in your back pocket is the Mental Capacity Act of 2005, and it's built on some really important ideas. We have to start by assuming every patient has capacity. And this is a big one. Just because a decision seems unwise to us, that does not mean the patient can't make it. And if there's a valid advance decision in place, we have to respect it. Period.
Now this is where things get really interesting, because it's not as simple as no blood products. Not at all. The acceptability of different things varies massively from person to person. Sure, primary components like red cells and plasma are usually a no-go. But what about cell salvage, or clotting factors, or even something like an epidural blood patch? That's all a bit of a gray area. So the absolute key takeaway here is you must have a specific, detailed chat with every single patient to figure out exactly what's okay for them.
So let's see how those principles translate into preoperative care. This is where really thorough preparation becomes the cornerstone of a safe outcome. This whole phase is what we call the first pillar of patient blood management. You're optimizing the patient before they even get to the operating theater. You've got to have a system, right? And it breaks down pretty neatly into these 5 key steps. It all kicks off with identifying these patients as early as you possibly can. That then triggers a big team meeting. You want surgeons, anesthesiasts, hematologists all in the room. From there, it's about shared decision-making, getting rock-solid documentation, optimizing their blood count, and planning all the logistics for the day of surgery.
Okay, if there's one number to jot down from this section, it's this: 130 grams per liter. The Association of Anesthetists guidelines from 2018 say we should be offering iron therapy to any patient with a hemoglobin below this level. And get this, if surgery is less than 4 weeks away, you need to be thinking about giving that iron parenterally to get their hemoglobin up in time. So the lesson here, identify early, plan as a team, and be aggressive about optimizing that HB.
All right, we're prepped. Now we're in the operating theater. This is where that second pillar of patient blood management really kicks in, actively minimizing blood loss during the procedure. And we've got a whole bunch of strategies we can use.
Your choice of anesthetic technique really matters. We've got meta-analyses showing that neuraxial techniques, like a spinal, can cut blood loss by up to 335 mils compared to a general anesthetic for major surgery on the lower limbs or abdomen. That's a huge deal, and it's all thanks to the sympathetic blockade dropping the arterial and venous pressures.
Think of these as the core tools in your intraoperative toolkit. Some are just fundamentals of good anesthesia, right? Like keeping the patient warm to avoid a hypothermia-induced coagulopathy and positioning them carefully to stop venous pooling. Others are specific things we do, like giving tranexamic acid or using permissive hypotension, though you have to be super careful with that one. And of course, nothing beats a surgeon with a meticulous technique.
Intraoperative cell salvage is an absolute game changer, and it's often acceptable to patients. And the data really backs it up. It can slash the need for donor blood by anywhere from 37 to 49% in big cases. Now, a really key practical tip here is that some patients might ask for a system that keeps the blood in continuous contact with their body, and you can actually achieve that with a simple primed giving set.
Okay, deep breaths. This is the scenario we all hope never happens, but we absolutely have to be ready for it. This is where a calm, systematic response based on a pre-agreed crisis plan is non-negotiable. It's the ultimate test of all your preparation.
So, in a major hemorrhage, you follow the protocol. And notice the first step.
call for help. And that doesn't just mean one person. You need at least 2 consultants there now. Then you hit the standard resuscitation basics, warmed fluids, active warming. At the same time, you're investigating with point-of-care tests like ROTEM or TEG, that's rotational thromboelastometry, and it gives you a live picture of the whole clotting cascade to really target your therapy. You send off labs for fibrinogen and calcium, you treat the coagulopathy with tranexamic acid and whatever other factors the patient has agreed to, and all the while the #1 goal is to stop the bleeding, whether that's surgically or with interventional radiology.
Now, you need to be aware of the alternatives, but you have to know their source and their risks inside and out. For example, recombinant factor VIIa isn't derived from human plasma, so it might be okay. But it comes with a high risk of thrombosis, and you should only use it with extreme caution and specialist advice. On the other hand, fibrinogen concentrate is plasma-derived, so a lot of patients won't accept it. Your exam takeaway is this. In a crisis, have a strict protocol, get senior help immediately, and use point-of-care testing to guide very specific pre-agreed treatments.
All right, let's shift gears and focus on obstetrics. This is a common and really high-stakes topic for exams. In this setting, a hemorrhage can be sudden, completely unpredictable, and massive, which makes that meticulous planning we talked about even more critical.
Here is another one of those magic numbers you need to have locked away for your exams. If you have a bleeding obstetric patient and her plasma fibrinogen drops below 2 grams per liter, that is a huge red flag. It strongly predicts that she's going to progress to a major hemorrhage. And just for context, a normal fibrinogen level at term is way higher, like 4 to 7, so a drop to 2 is a massive, massive fall.
So, here's a tricky little clinical puzzle you might face that really tests your understanding of all these principles. We all know an epidural blood patch is the gold standard for a post-dural puncture headache, but it involves injecting the patient's own blood. So how on earth do you do that if the patient finds that unacceptable?
And the answer is actually pretty clever. It all lies in tweaking the technique. Use a sterile extension tube to connect the IV catheter directly to the 2i needle. What you've done is create a continuous, unbroken circuit, so technically the blood never actually leaves the patient's circulatory system. This simple little modification might just make the whole procedure acceptable, and it's a great example of creative, patient-centered problem solving.
So when you boil it all down, this entire approach, from that very first clinic visit to the final post-op check, it's all built on these 3 pillars of patient blood management. Number 1, optimize the patient's own blood before surgery. Number 2, lose as little blood as possible during surgery. And number 3, manage and support the patient's ability to tolerate any anemia that results. It's a really complete framework.
And I just want to leave you with this final thought. All these specialized techniques and this incredibly meticulous planning we've been talking about, they're not just for a small group of patients. This is the pinnacle of best practice. If we start applying these principles of patient blood management across the board, we can reduce the risks that come with transfusions and improve outcomes for every single patient that we care for.
This explainer was based on the article Perioperative Care of Patients Who Decline Blood Products by Prabhu and colleagues from BJA Education, Volume 26, Issue 1.